Ma'am, please start.
Hello everyone. So today I'll be discussing about hair disorders. So I'll briefly cover the topic here and tell you what important questions are asked in this topic. So first of all, you should be know that we have three different types of hairs, and you should know broadly the difference between these three types of hair. So lanugo hair is soft unmodulated hair, which is the hair which we usually see when a newborn is born. So it's basically in utero hair which is there. So it's very, very soft. It is unpigmented and unmodulated. The second and the third type, which is vellus and terminal hair, is the hair which we usually have on our body. So vellus hair is again soft and unmodulated, but occasionally it can be pigmented. It is the hair that you usually have it on your face. Very, very fine, thin hair that you see on your face is vellus hair. The third is the terminal hair, which is usually hormonal dependent. So it comes after you attain puberty. So these are longer, they are coarser, they are methylated, and they are pigmented. So the hair in the pubic area, the hair in the axillary area, or the hair in the people who have hirsutism are all terminal hair. The beard hair is also terminal hair. So these are dependent on the hormones. The second thing about hair that you should be knowing is the hair structure, that it is divided into infundibulum, which is the part of the hair from the epidermis till the sebaceous gland is there. From the sebaceous gland till the insertion of rectopili muscle, we have isthmus. And below that, we have the hair root, which has the suprabulbar area and the bulbar area. Now, it is the bulbar area which is very, very important, the bulb and the suprabulbar area, because here lies the stem cells. So if we destroy the hair at the level of this area, at the level of stem cells, we get what is called a cicatricial or scarring alopecia, that is the hair won't grow back. Whereas if we if there is any damage to the hair above this level, then the chances of hair getting back is high. Okay, so next important thing in hair is the hair growth cycle. Now we all need to know that when our hair is growing, so a hair strand which is growing does not stay forever. So a hair goes through three main phases. So these three phases are anagen, catagen, and telogen hair. The anagen hair is the hair of growth phase, in which my hair is growing, followed by a transition phase, which is called as catagen, and then a falling phase, which is called as telogen. Okay, now what is the difference between these three phases and why are they important? See, this is how an anagen root looks like, a proper bulb, whereas telogen is like a club root. A hair first will grow and be in the anagen phase. Now this anagen phase lasts for approximately 3 years, 2 to 3 years. So a hair which starts growing grows for 2 to 3 years. Then there is a transition phase which is of 3 weeks, and then there is a falling phase. So once the hair goes into the telogen phase, it stays in that phase for 3 months and then it will fall off. So it goes in the cycle. So once the hair falls from the telogen phase, the same bulb, the same hair root will again convert into the anagen hair root, and from the same root, a new hair would come. Okay, so now this is something which you need to really know, that this anagen phase is for 3 to 5 years, and roughly my 90% of hair are in the anagen phase. Okay, so the hair which are there, so if I pluck them and see them under the microscope, I would see that 90% of my hair, that anagen bulb. Then there is just 1 to 2% of hair which are there in the catagen phase, so which is not relevant for you, but there are 8 to 10% of hair are in the telogen phase. So the amount of hair shedding that you see, like when you comb, when you do shampooing, you see some amount of hair strands coming out, right? They are all telogen phase, telogen hair, which will come out eventually. Only when they come out from the same hair root, a new hair will form. Okay, so you should know, you can remember it like this: anagen is for 3 years, catagen is for 3 weeks, and telogen is for 3 months. 3 years, 3 weeks, 3 months. And 90% hair are in the anagen phase and 10% hair are in the telogen phase. Now, since 10% are telogen phase and they have to shed, approximately 50 to 100 hair shedding per day is normal. So when a patient comes to you and tell you that my hair is shedding, ask them that how much is shedding. They just say there are 3 to 4 hair shedding per day. It's completely normal. So up to 50 to 100 hair shedding per day is considered. Okay. Now this is also important when we will study about different types of alopecia. So you should know about this stages of hair growth. Also know that hair grows at a rate of 1 centimeter per month or approximately 0.35 mm per day. So only 1 centimeter hair grows in a month. Remember that. Now coming to the hair disorders we can classify broadly into 2 categories. One category would be where we would be losing hair, which is called as alopecia, and the second category would be where we would be having more hair, which can be hypertrichosis or hirsutism. Hypertrichosis is when there is generalized increased hair growth, which happens after topical steroid application. It can be congenital. And hirsutism is a hormonal dependent hair growth that is seen in females. Okay, we'll talk about it in detail. And so we come to the first category, which is disorders of hair loss, which is called as alopecia. Now, alopecia or disorders of hair loss are further divided into 2 categories: scarring and non-scarring. Scarring is also called as cicatricial, and non-scarring is also called as non-cicatricial alopecia. So what is non-scarring alopecia? Non-scarring is when my hair stem cells are not getting damaged, and so the chances of hair coming back are very, very high. Whereas cicatricial alopecia is where there is scarring, where my hair bulb is being destroyed, my hair stem cells are being destroyed, and so the chances of hair coming back are very, very less. There are different tests which are done for hair, which are not asked you in detail. So we'll straight away come to non-cicatricial alopecia, where there are high chances of hair coming back because here the pathology is not affecting the hair stem cells. Okay. Now, when we talk about non-cicatricial alopecia in hair, this is a very, very important topic for you because usually you're given questions where you have to differentiate between different types of non-cicatricial alopecia. So they are broadly divided into 3 categories: patterned hair loss, which is also called as androgenetic alopecia; diffuse hair loss, which can happen with various effluviums; and patchy hair loss, which happens with usually alopecia areata. Okay, so these are 3 types of non-cicatricial alopecia. Whenever they give you a question on non-cicatricial alopecia, they will usually give these options, and you should know how to differentiate between these 3 types. So coming first to the androgenetic alopecia, which is also called as male pattern hair loss or female pattern hair loss. So it's of 2 types. If it affects the males, it's called as male pattern hair loss or male androgenetic alopecia. If it affects the females, it is called as female pattern hair loss or female androgenetic alopecia. Now, before we move on, what is androgenetic alopecia? Here, basically, it's the role of androgens, which is causing the hair thinning. Now, this is known to be associated with certain disorders like metabolic syndrome. It is associated with some cases with prostate cancer. But the most important association that we see with androgenetic alopecia is metabolic syndrome. Now, what happens in androgenetic alopecia? We all know that our body has a hormone which is called as testosterone. Now, this testosterone converts into its active metabolite, which is dihydrotestosterone, with the help of an enzyme which is 5-alpha reductase. Now, this enzyme converts testosterone to DHT. This DHT, what does it do? Look at the picture. So, this is on the left hand side is my normal hair bulb, which is thick, which is pigmented, which is good amount of, which has good amount of follicular density also. Like each follicle usually have 3 to 4 hairs coming out of it. DHT causes this hair to become short. It causes it to become fine, hypopigmented, and miniaturized. So my terminal hairs are converted into vellus hairs. So my hair, DHT causes my hair to become less pigmented, less thick, very fine, and miniaturization happens. So that is why androgenetic alopecia patient comes to you not with a fall person. The patient says that my hair density is coming down. Why? A thick, a pigmented hair will definitely give more density to the hair. Whereas if you have very, very fine, thin hair, and here my scalp would appear bald. Okay, so DHT causes baldness. DHT causes these hairs, terminal hairs, to appear more like vellus hair. So there is a change in ratio of terminal to vellus hair, which is usually terminal to vellus hair is usually 8:1, and that becomes 4:1. So for every 4 terminal hair, I have 1 vellus hair. Whereas for 8:8, I should be having 1. So almost 50% hair is converted into vellus hair. Also, it leads to changes in the hair cycle. So my anagen to telogen ratio, which is usually 9:1, 12:1, changes to 5:1. So I have more hair in the telogen phase, I have more hair which are there in the vellus phase. And that gives rise to loss of density. So this is how the patient presents to me with. This was a grade which was going to be given by Norwood and Hamilton, who classified the male pattern of baldness into 1 to 7 grades. So patients usually start with first grade, and if untreated, if does not take any treatment, goes to grade 7. Okay, this was a grading which was given by Norwood and Hamilton. So as you can see, it starts with frontotemporal recession, and then eventually there is vortex balding, that is C. Clinically, it appears like this. So a lot of time we've given an image like this and asked what is the diagnosis. This is androgenetic alopecia, which typically has frontotemporal recession and vortex balding. So there is loss of density, there is miniaturization of hair that happens. In females, the female androgenetic alopecia, we are still not sure. There is definitely a role of androgen, but how much we are not very sure. So in females, the pattern that we see is more of like widening of the central part. In females, we do not see this recession or vortex balding. What we see is that there is the central the parting which is there, which usually females have, that starts to widen. So there is balding effect which is seen on this area, and that is usually seen as widening of central parting. And as it progresses, it gives rise to this Christmas tree pattern, as you can see in the third image. Now, this grading was given by Ludwig, and so it's called as Ludwig's grading, grade 1, 2, 3 of PDA pattern hair. Now, sometimes even males can have a Ludwig pattern of hair loss. Okay, so we can ignore that fact. For you, you should remember Ludwig's staging is for FPHL and all is for male pattern hair loss. Okay, so a lot of times they might give you a female like this. And you might think there is no vortex balding, there is no frontotemporal recession, it cannot be HA. This is HA. This is androgenetic alopecia. In females, it presents like this. How do I manage these patients? So you have to tell them that this is a hormone which your body is producing. So treatment of AGA is for lifelong. A lot of time patients would start treatment and then they would not do complete treatment, or they would believe that if I leave the treatment, my hair would fall. So you have to counsel them that it's not the treatment, it is the cause which is the problem. So androgens or testosterone is something which is very essential. And so if we stop the treatment, they will again start acting on my hair and again cause miniaturization. So the treatment of AGA is very, very long, almost lifelong. So you can give the patient an option of doing camouflage. They can wear wigs, they can so they can cover up, but that's because if they are not able to carry on the treatment for long, there would be no effect, or whatever effect they get would come. So how do we treat androgenetic alopecia? There are medical treatments which includes anti-androgens. These are basically 5-alpha reductase inhibitors like finasteride. So my finasteride is one of the major drugs which works against 5-alpha reductase. And so what does it do? So the testosterone which was getting converted to DHT does not get converted, and that really helps. The other agent which is used is topical minoxidil, which is a potassium channel opener. It causes vasodilatation. So there is increased blood flow through these hair follicles and my hair improved. Another agent which is used is dutasteride, which is both a type 1 and type 2 5-alpha reductase inhibitor. However, we use finasteride more commonly. Most of the time, you get questioned, you get this image, and you are asked for treatment. So, our treatment for androgenetic alopecia is finasteride and topical minoxidil. In females, we usually do not give finasteride. We can give, but we prefer anti-androgen therapy with synchrotron acetate, with spironolactone, and those are more commonly used. However, you can also use finasteride or glutamine for females. So, topical minoxidil and finasteride are my mainstay of treatment for androgenetic alopecia. Apart from this, you can go for surgical management, which includes platelet-rich plasma, in which the patient's blood is taken, centrifuge, growth factors are extracted, and then injected into the hair. And hair transplant, which we all are aware. Now, in hair transplant, remember how does hair transplant work? In hair transplant, you take the hair from the occipital area. Remember, my occipital part of the scalp is not dependent on androgens. So, when I take hair from the occipital area and implant it on this area, the hair has a property that from where it is transplanted, it retains the property of the parent cell. So, a hair which is taken from occipital area and transplanted hair will retain the property of the occipital side and so will not thin out. That's the principle of the That's a very, very basic principle of the hair transplant. So, hair transplant is also used for androgenetic alopecia. The next in non-cicatricial alopecias are effluviums. Effluviums are basically disorders of hair cycle. So they can be anagen or telogen. So, like for example, if a patient is on chemotherapy, what does chemotherapy do? Chemotherapy destroys all actively dividing cells. Okay. Now, when it does so, when it destroys these actively dividing cells, anagen phase is my actively dividing phase. It's the growth phase. So that gets affected. It also arrests the growth at the anagen phase, and all my anagen hair follicles, they are lost. Now, since anagen hair forms 90% of the hair, that's why what I see is global alopecia. I see all my hair falling off. That's why after chemotherapy, you see that the patient goes bald because anagen, which is my active phase, the growth in that gets arrested, and all my anagen hairs are lost. This is called as Androgenetic Alopecia and is seen in patients with chemotherapy. Very commonly, what we see in our clinical practice is called as telogen effluvium. Now, what happens in telogen effluvium is, now suppose my body undergoes any kind of stress, dengue, chikungunya, COVID. What happens during that time? The body's nutritional supply reduces. So, what does my body do? The body does not give any nutrition to my hair. So, what does hair do to compensate? Now, if the hair will be in the growing phase, it will need more nutrition. So, what does the hair do? Hair converts itself into telogen phase so that its requirement during stress reduces. So, now what is happening? My anagen, which was a predominant stage of hair growth, gets converted into telogen phase. So, when it goes into the telogen phase, I do the telogen phases for 3 months. So, the hair lies there for 3 months and then starts to shed. So, now what happens in telogen effluvium is, like suppose a patient had dengue or COVID. Now, during that stressful period, my almost 50% hair goes into the telogen phase. So, after 3 months of this insult, all this telogen hair will fall. So, suddenly we see a sudden increase in hair fall that happens 3 months after any insult. Now, this insult can be COVID, dengue, chikungunya, it can be stress, it can be heart disease, it can be heart attack, it can be any surgery, any mental stress, pregnancy. All this can lead to this conversion, premature conversion of anagen into telogen and sudden shedding of telogen hair, and this is called as telogen effluvium. Now, when a patient comes to with telogen effluvium, remember you have to just counsel the patient that you might feel all your hair are losing, but they will come back because it's just a cycle disturbance. Once the hair in the telogen phase falls, from the same bulb, I'll see a new hair growing and eventually you'll get back hair. So counseling and some multivitamins are all that are needed for telogen effluvium, nothing else. Okay. The third type of non-cicatricial alopecia is called as Alopecia Areata. Now, what is Alopecia Areata? It's an autoimmune disorder. It's an autoimmune disorder where my T cells, they start acting against my hair follicle. Now, what happens here is when my T cells act against the hair follicle, whichever area they decide to act, there again, this hair, my lymphocytes or T cells, will damage my anagen hair. So, what does that do? This anagen hair sheds itself. The hair gets shed from there, and that area bears bald. So, here the patient present to me with a circular bald patches of alopecia. So, here what is happening? My immune cells are targeting the anagen phase of the hair follicle. So, to escape from the immune cells, what does anagen do? It sheds off its hair and goes into the other phase, telogen phase. Now, this telogen will again go into the anagen phase. Again, my anagen hair will be shed off, and that leads to alopecia areata. This is an autoimmune condition with genetic association C. Also, since it's an autoimmune condition, it is associated with other autoimmune problems like hypothyroidism, pernicious anemia, vitiligo. So whenever I see a patient of alopecia areata, I also look for presence of other autoimmune disorders. This is how it is presented. Very, very well defined, very, very circular patches of alopecia, and they will be bald, smooth patches, unlike tinea capitis. In tinea capitis, also you see circular patches of alopecia. But in them, you have the scaling, you have black dots, or if it's a chemion, you see a boggy swelling. But alopecia areata is smooth. It's a pelade. Alopecia areata comes from the term pelade, which means smooth. So here I have smooth patches of alopecia, very, very smooth patches of alopecia. That is there. Very circular, very smooth looking patches. Okay. And now another sign that we see, so you can have a single patch or you can have multiple patches. You can see a single patch or you can see multiple small patches. There is an important sign which is associated with alopecia areata, which is called as exclamation mark here. Now at the periphery of the alopecia areata patches, you see something which is called as exclamation mark here. Now, what is exclamation mark here? The antigen which is targeted by the lymphocytes, you see a kink between the bulb. So, I have a bulb below and I have a hair shaft above, and that's called as the exclamation mark here. This is usually seen at the periphery of the alopecia areata. So, in exams, sometimes they ask you this exclamation mark here is seen, or in the clinical scenario, they will give you a presence of exclamation mark here or an image like this. So when this is seen, you know that you're dealing with alopecia areata. Now, alopecia areata can be of multiple types. It can be patchy, as I just showed you, or sometimes you may see a complete loss of hair on the scalp, which is called as alopecia totalis. Whereas sometimes you might see complete loss of hair throughout the body, very severe form of alopecia areata, where all the hair in the body are lost. Like in this image, this is called as alopecia universalis. So universalis is when there is hair loss throughout the body. Totalis is when there is loss of hair on the scalp. Okay. Then there is a pattern in which just the occipital part of the scalp is affected, which is called as ophiasis pattern. Ophiasis pattern. All these are poor prognostic markers. All these are poor prognostic markers. If you have ophiasis pattern, if you have universalis, if you have totalis, so these are all bad alopecia areata. Sometimes you may have alopecia areata, which is just limited to the eyebrows, or in males you might have beard area which is affected. So because terminal hair is affected, so anywhere in the body terminal hair might get affected. Okay, so sometimes you get an image like this. So remember, this is not just seen on the scalp, it can be seen on other terminal hair areas of the body as well. This is a very, very poor prognostic alopecia areata, which is called as the reticular pattern. Here you have multiple circular patches of alopecia, which is present in the reticular pattern. Now, in alopecia areata, there are also certain nail changes that are seen. One of them being the most common one being pits. Now here you see pits, you see also pits in psoriasis, but how is it different? Here I have what is called as geographic pattern of pits. The pits are very, very regular, they are very, very small, and they are very, very geometrical areas, so not geographical, geometric pattern of pits. So here I have very small geometric pits which are arranged in a very regular fashion. Whereas in psoriasis, I have very deep pits, I have random pits, I have irregular pits. but here they are very regular and they are present in a very geometric pattern. Also, what you can see is called as Trichotillomania, which is this, where you see longitudinal ridging, where you see roughening of the nail plate and all the nail plates may be destroyed. This is called as Trichotillomania and is also a feature of Alopecia Areata. Now, when we see a patient of Alopecia Areata, even in exams, you may get these DDs along with it, because as I told you, there is circular patch of alopecia. You might see circular patch of alopecia in tinea capitis also. How will you differentiate? In tinea capitis, there will be scaling, there may be black dots, or a QH would be positive. So in the question, somewhere they will give you a QH positivity, black dots presence, or scaling presence. Okay. Sometimes you may also have differentiated from Trichotillomania, which I'll just explain later. Then there is something called as moth-eaten alopecia, which you see in syphilis. So that also presents with circular patches of alopecia. So how do you differentiate it from Alopecia areata? Remember, syphilis will never present just with moth-eaten alopecia. Syphilis patients will have usually other manifestations of secondary syphilis, and obviously VRL will be positive. Just moth-eaten alopecia will not be a feature of syphilis. There are certain poor prognostic factors with Alopecia areata, like the patterns that I told you, totalis, universalis, reticular pattern, ophiacis pattern, a positive family history, presence of other autoimmune disorders, presence of Down syndrome. All these are poor prognostic factors, and if present, you should counsel the patient accordingly. How do you treat Alopecia areata? The first thing that you do is spontaneous resolution can happen. So you should counsel the patient. You have to counsel the patient that spontaneous resolution is a possibility, that there is a single patch, and then what happens, my immune system corrects itself, and sometimes patient may get back to it. So sometimes patient will tell you that I just had this patch, and you can tell the patient that maybe you can wait for 1 or 2 months if it's a very small patch. If you see a regrowth, that means your body auto-corrected itself, and so you don't need it. However, if it is a persistent patch, if there are multiple patches, if it is growing, then you need to treat. And the treatment of choice is intralesional steroids. Intralesional steroids are my treatment of choice for Alopecia areata, especially if I have a limited disease. By limited, I mean less than 5 to 6 patches. However, if we have multiple patches, you cannot inject. So intralesional steroid is injecting steroids into the patches of alopecia. So here what I'm trying to do basically is I give intradermal injections of triamcinolone or Kinacort. Now these, as the inflammation is localized around their hair follicles, this injection kind of takes away that inflammation and the disease subsides. So this is the best treatment if the patient has limited disease. However, if the patient has multiple patches, if the patient has severe alopecia universalis, totalis, then we need to resort to oral corticosteroids or other immunosuppressive therapies. The another thing that is used for Alopecia areata is called as contact immunotherapy. Contact immunotherapy is use of different contact allergens, DPCP, dinitrochlorobenzene. Now, what do these do? These are basically allergens. So when you put it on the patch of alopecia, now this, since it's an allergen, it will stimulate a reaction which is called as contact allergic dermatitis. Now, when this is generated, the immune reactants which have come to damage the hair follicle will come and act on these dermatitis. Contact allergic dermatitis also needs immune responses. So they will be directed towards that, and they will forget about the hair follicle, and my hair will start growing. So it's an indirect way to improve alopecia areata. Okay, so contact immunotherapy is also used for alopecia areata. So my treatment of choice remains intralesional steroid, but if they ask you what are the options to treat alopecia areata, it's intralesional steroid, corticosteroids. You can also use immunosuppressive agents, you can use methotrexate. And now there is a newer agent which is called as tofacitinib, which is a JAK kinase inhibitor, which is also used for alopecia areata. So this is a new agent by the name of tofacitinib, which is a JAK kinase inhibitor, and that is used for alopecia areata. Next, coming to trichotillomania. Trichotillomania, as I was telling you, is a degree of tinea capitis. What is it? You again get lots of questions on trichotillomania. It's a psychiatric disorder in which the patient has a habit of pulling hair. Okay, now remember, if a patient has a habit of pulling hair, we usually do it on the accessible part of the scalp. Like, patient would not realize he's doing it, but like whenever he's thinking or studying. So the dominant part, so like if right hand is my dominant hand, then right frontotemporal area, I'll keep pulling the hairs like this. I'll keep pulling the hairs like this. And so I get a patch of alopecia, which is something like this, where there are hairs which are of various lengths. Okay, so when we pull, we will not be exerting a common force. Sometimes it will be hard, sometimes it will be low. So my hair shaft will break at different lengths. Okay, so this is called as trichotillomania. This is a psychiatric disorder. So usually in the question, they will give you something which is suggestive of a psychiatric disorder. They will give you a accessible area, a frontotemporal area, and they will mention that there are broken hairs of different lengths which are there. And because the patient is pulling, this is a trauma, this leads to perifollicular hemorrhages also. The treatment for trichotillomania is doing a behavioral cognitive therapy, giving antidepressants to the patients and other antipsychotic medication. But look at the picture, it's very different. There's no smooth patch of alopecia. There are hairs which are present, but they are of various lengths. Okay. Very, very briefly about cicatricial alopecia. Cicatricial alopecia is a patchy hair loss which leads to permanent destruction of hair follicles. Here, there is a damage to the stem cell which is happening. And since there is damage to the stem cell, I do not get back hair. So when a patient of cicatricial alopecia comes to you, counsel that I'm treating you to prevent further damage. But whatever area is scarred, you cannot get back the hair because there the hair bulb cells are destroyed. Now, important in cicatricial alopecia is what are the causes? So one is follicular LP, lichen planus. When it affects the hair follicles, it is called as follicular LP, and that leads to cicatricial alopecia. Then the other important reason for cicatricial alopecia is DLE or discoid nevus erythematosus. Again, a DLE patch when present on the scalp will lead to damage of the follicular bulb cells, and that leads to cicatricial alopecia. The third important cause of cicatricial alopecia is pseudopelade of Brock, which is basically an idiopathic condition. Here, we do not know what is the cause, but there is some cause which has led to patchy cicatricial alopecia without any evidence of inflammation. So in LP, in DLE, you know that causes LP or DLE, and you know there is inflammation which is happening. But in pseudopelade of Brock, you do not get any inflammation. So it is idiopathic, it is chronic, it is slowly progressive cicatricial alopecia without any evidence of inflammation. So here, what you see is something like this, which is called as footprints in snow parents. So footprints in snow parents is typical of pseudopelade of Brock, and that is what is asked in pseudopelade of Brock, and mostly what is asked in cicatricial alopecia. Footprints in snow parents, or they'll give an image like this and ask you seen in pseudopelade of Brock. Okay. So this is what you need to know about cicatricial alopecia, very briefly covering hirsutism. So what is hirsutism? Hirsutism is when you get unwanted hair. So when females, they start getting hair in the areas where hair should not be present, in the androgen dependent areas like the beard area, where like the chin area, the cheek area, the mustache area, when females start getting hair on these areas, this is called as hirsutism. And how do you define hirsutism? Hirsutism, there's no definition per se. It's when the patient is getting bothered. So suppose patient has a lot of hair and it's not getting bothered, you do not. But if even there are few hairs and it's bothering the patient, then you. So here what is happening is that there is some hyperandrogenemia that is happening. There is increased androgen which is happening, or the androgens are binding more to the skin receptors, leading to the more action of androgen on the skin, which leads to hirsutism. There are various causes of hirsutism, and hirsutism is basically because of hyperandrogenism, which can happen due to either the ovarian cause or the adrenal cause. We all know androgens are present from adrenals or ovarian. So either my adrenals are hyperreactive or they have a tumor, or my ovarian process like PCOS, congenital adrenal hyperplasias, virilizing tumors, Saha syndrome, or in some cases we see that they're idiopathic. We do not identify any cause. In those, we believe that probably there are more receptors in the skin where my androgens are going and binding and acting more and giving rise to more prominent hair. So this is how the patient presents to me with. There is a scoring system which is called as Ferryman and Galway scoring system. Now here, whenever a patient of hirsutism comes to us, what we have to do is we have to evaluate them. We have to do their whole hormonal profile, look for causes of hyperandrogenism. You have to look for hypothyroidism, hyperprolactinemia. So you do a complete hormonal profile and only then treat the patient. Because if you start treating the patient without looking at the cause, there is a chance that patient may get back hair. How do you treat these patients? Laser hair reduction is done for whatever hair have grown, and for whatever cause we identify of hyperandrogenism, the patient needs to be treated for that. So patient can be given anti-androgens like cyproterone acetate, electron. If there is PCOS, you can give the patient OCPs. If the patient has both the things, you can combine your OCPs and aldactone. You should also look for insulin resistance in this patient and give them metformin if needed. So this is in brief about hair disorders, and I tried to cover the important topics and important questions here. So in case there are any queries, I'll be willing to take them now.